Right. How is everyone? Guys, turn your cameras on. Let me see some faces. Seeing you all after a long time. Hey, Niha. Some of you have grown beards. Who is here today? Guys, turn your cameras on. Otherwise, I will be taking you all out of the meeting. Amalinda is here. Shabib is here. Who else? Sachit, I thought Tarinder was here. I saw Tarinder. Right. Okay. Right. Look here, guys. So today we are talking about the second topic in our hematology module, iron deficiency anemia. Now, ideally, this would be the first topic to discuss under hematology, but we had a little issues with scheduling because we have to go to hospital these few days. Anyways, so today we'll be talking about iron deficiency anemia and tomorrow thalassemia. Right. Right. Let me share the screen. Before I share the screen, can someone in the meantime tell me what do you all know about iron and iron deficiency? Anything you all know, because we are going to start from the basics. We're going to start from iron metabolism itself. Anything you all know about iron or iron deficiency? Have you all seen an iron deficiency patient? Right? What do you all know? Any manifestations that you all know? Anything, right? Until I share the screen, someone just unmute and tell me anything you all know about it. Anyone? Give me a second. Right. Guys, can you all see the screen? Give me a thumbs up if you all can see the screen. All good? Right. Excellent. Just this a little. I haven't used Zoom also a while. I've forgotten how to use Zoom also. Right. There we go. Okay. So I can see only three faces in front of me. Guys, others turn your cameras on. Okay. Right. Iron deficiency anemia, right? So we are going to start from the very basic, guys. The first few things I want you all to know just to get an idea, right? Our total body iron, right? If you look at the total body iron in a person, in a healthy adult, right, at any given time, right? Usually, guys, in males and females, this varies slightly, right? In a male, they have about 50 milligrams of iron per kilogram of body weight. Okay, this is males, and you all can write, guys, males plus postmenopausal females. Right? Males and postmenopausal females, we have about 50 milligrams of iron per kilogram of body weight, whereas females of reproductive age, right, who have their regular periods, regular menstrual cycle, right, for them, they have a little bit less, about 40 milligrams per kilogram of body weight, right, about 40 milligrams of iron per kilogram of body weight. Now, this is basically due to the menstrual losses. Then there are some exceptions, guys. For example, during pregnancy and lactation, these values change a little. We'll talk about that a little later, right? For now, you should know this much. So overall, in a male or a postmenopausal female, we say they have about, depends on their weight, but average 60 to 70 kilogram person, they will have about 4 to 5 grams of iron in their body, about 4 to 5 grams of iron in their body. Whereas a female of reproductive age, right, they have about 2 to 4, we say 2 to 4 grams of iron in the body. Okay, now these values, obviously, they are subject to change, right, depending on the area, depending on the diet in the community. All of these can affect this iron concentrations, right? whatever happens, what I want you all to know, what's constant is, guys, out of these values, right? About 30 milligrams per day is used. 30 milligrams of iron per day is used to make new hemoglobin, hemoglobin synthesis, right? Whatever value the person has in his body, doesn't matter. About 30 milligrams are used per day to make new hemoglobin. Okay, right. Then, once we consider this body iron, another important thing to know is the different forms, guys. Is the different forms of iron. For example, we have, give me a second. There we go. Right? We have something called the functional form, which consists about 80%, right? 80% of all the iron. We have another one of storage form, that's about another 15%, and we have one more. This is in transit, right? During transport, right? You can just write transport in the circulation, transport within the circulation. We have about 5%, right? Look at this case, functional form. What functional form? If I ask you, what is the main function of iron in a human's body? What is your answer? Main one. There are obviously a lot. What is the main function? Huh? Just now we discussed.
Make hemoglobin.
Make hemoglobin, right? So likewise, guys, just like that, hemoglobin is the major functional form. It accounts to 70 to 80% here, right? And we have, so out of that 80%, another 70 to 80% of that 80% is hemoglobin. You all know a percentage of a percentage. That's what I'm talking about here, right? And then you have in the muscle, guys, what we have? Myoglobin is a very small number. We have about 5 to 10% myoglobin, right? And then the remaining very 1 to 2% is distributed among other structures, guys, especially these enzymes, right? We call them cytochrome, the cytochrome enzyme families, right? Cytochromes, all these mitochondria related enzymes, right? Catalases, right? These kinds of structures, right? They will have a little bit of iron here and there. That's a very small amount, minute amount, about 1 to 2%. So all of these three together form the functional forms of iron, right? Functional forms of iron. Then when we look at the storage form, right? Mainly two. Does anyone know the two main storage forms of iron? Unmute and talk, interact. Anyone? No? Sachit, what are the two storage forms of iron? Give me one. Iron, guys, can we store iron in the iron form as a ferrous iron or a ferric iron? Can we store it directly just in the body? No, there are some other structures coming into play. I will describe them. Right, okay, there are two. Write this down. Ferritin is one, right? The other one is hemosiderin, right? Ferritin and hemosiderin. Out of these guys, if you look at the percentage, the majority is ferritin. 2/3 is ferritin and about 1/3 is hemosiderin. Ferritin and hemosiderin. Don't worry, all these words, I will teach them what they are. Then iron in transport. What is this transport part, guys? There is some iron being transported in our circulation, right? Now, iron does not transport by itself, right? It has a special molecule to transfer it around the body in the circulation. This is what we call transferring, right? Transferring. Okay, we will talk about this transferring also. But basically, this is your body iron distribution, guys. Body iron distribution, right? Now, obviously, you all know hemoglobin. If you take the hemoglobin form, so this one, where is hemoglobin synthesized? In the bone, right? Mainly in the bone marrow. So a majority will be there, right? Then there is a little bit myoglobin, right? Like that, it will spread out across your body's organs. But these are the main forms, right? Right. Then another last point to mention under this introduction part, guys, iron loss, daily iron loss, right? Iron loss. If we look at iron loss, guys, in a male, right? In a male, and obviously postmenopausal female, right? We have about 1 milligram per day loss of iron. 1 milligram per day loss of iron, right? From the body, iron is lost. How does this happen, guys? In a male, how will this happen? How will this happen? How will you lose iron? Huh? Anyone? Shashank is also here. Shashank, how will we lose iron? Huh? How do you and I lose iron? How do we lose anything? Huh?
Urine.
Yeah, excellent, right? Urine, right? Fecal matter. Don't be afraid to answer. Urine, fecal matter. And then sweat also. Some sweat also, right? We lose some iron. Then, guys, in females of reproductive age, right? They have a little bit of extra, right? We say about 1.5 milligrams when you take the average, right? About 1.5 milligrams a day. They also have these urine, fecal matter, and sweat loss. Apart from that, what do they have? Menstruation, right? Menstruation. So that is their extra method. So that's why they lose a little bit more, right? Right. Then again, just write in a star or in a bracket or something, just put pregnancy and lactation different. Pregnancy and lactation, we will talk about, right? The iron loss is a little bit, especially for during the pregnancy, iron loss is very much higher, right? Sometimes 3, sometimes 4 milligrams a day, right? Or even higher. And lactation, it depends on if they're having a twin pregnancy, multiple pregnancy, right? Based on those factors, right? We'll talk about those in a little bit. Right. So because of this, so since we are losing iron like this, right? We have to definitely take it in our diet, right? In our diet, we have a recommended nutrient intake. We'll talk about that in a little bit, right? So now, having said that, we need to take iron. Let's start the metabolism from there itself. So you all can put the big topic, iron metabolism, right? So we will start, or we are going to break down this metabolism, guys, into 3 parts. Absorption from the gastrointestinal tract, right? And then we are going to talk about utilization. This is basically our hemoglobin synthesis. We are not going to go into too much depth, but we'll discuss a little bit there. And then we're going to talk about the storage as well. Right? So we'll start off from the very beginning. Take a new page, take this page. On the right corner, you all can draw a small GIT up to the, let's say, proximal duodenum. Right? Something like this. Right? Guys, tell me this. Where is iron primarily absorbed in our gastrointestinal tract? Which parts? Duodenum, yeah. I should not have drawn that. No, right. Duodenum, yes, correct. Mainly proximal duodenum, right? Proximal duodenum mainly, and sometimes a little bit more down and the early jejunum part as well, right? But mainly proximal duodenum, first part of the duodenum, right? That is there. And so you all know, guys, in this duodenal epithelium, we have what we call this brush border, right? It looks something, let me draw it a little bit nicer. It looks something like this, right? The brush border is towards the lumen, right? Something like this, no? So what we'll do, we'll take one of these cells and expand it. This is one cell expanded, right? Something like this, and the rest of the cells, again, you all can just draw them like that. Right? So one cell has been expanded there. Draw it a little bit more bigger. Something like that. There you go. Right? And then somewhere here, just draw a blood vessel. Right? This is, guys, now we are starting off with the first phase, absorption phase. Phase number 1. Okay, absorption phase. Right? Okay, now look here, guys. First thing, what did we say? We need to take iron in our diet, right? iron in our diet, guys, mainly two forms. Right? We have iron coming from animal products. Right? Basically, our meats, right? Right? This is what we call, guys, heme iron, right? Heme iron. Okay, heme iron. And then we have iron coming from our plant products, right? Fruits, vegetables, right? Anything non-meat, basically, right? Plant products. This is what we call inorganic iron. Inorganic iron, right? Now, I want you all to take two colors, right? Just take two colors, and we are going to use those two colors throughout this class, okay? Don't mix them up, right? For the heme, I'm going to use red, okay? For heme, I'm going to use red because, you know, hemoglobin, pink, reddish in color, okay? This is my thinking. Okay, heme, I'm going to use red. And for the inorganic or the plant-based one, I'm going to use blue. Why I want to differentiate this, guys? In heme, we get what we call ferrous form of iron, Fe2 plus, right? Ferrous, Fe2 plus. Whereas in inorganic iron, what do we get? We get ferric, right? Fe3 plus, ferric form of iron. Okay, ferrous and ferric, right? Fe2 plus, Fe3 plus, right? Now, throughout this pathophysio part, we are going to use these two colors. So for whenever I want to represent the ferrous iron or the heme iron, I'm going to use a red star, a red star like this. Whenever I want to use the ferric iron, plant-based, I'm going to use a blue star. This is how we're going to do it, right? Okay. Right. Now look at this. So when we are eating, right? When we are eating a meal, you all know when we take a usual meal, you will have maximum 1 to 2 portions of meat. You most of the time it's just one kind of meat, right? And maybe an egg or something. And then we have usually 3 to 4 different types of vegetables, right? That's what at least the healthy eating suggests, right? So when we take a generalized meal like that, usually we are getting iron from both forms coming in, right? So we will have heme iron coming from any animal products, and we will have this inorganic ferric iron coming through any plant products, right? Now, here's the important thing, guys. What I want you all to know, heme iron, before we move forward, just put a side note here. Heme iron, this one is easily and readily absorbed in our digestive tract. Heme iron. Whereas inorganic iron, much more difficult to absorb. We will see why, right? We will see why. Just know, when we take a meal out of the iron that is coming. So if heme iron is coming, 10 to 15% of that heme iron will be absorbed into our digestive tract, right? 10 to 15%. Whereas inorganic iron, guys, only 1 to 2% will be absorbed. Only 1 to 2% will be absorbed. So if I ask about bioavailability, which one is more bioavailable? Heme iron, gram to gram is more bioavailable, okay, right, in the human body, right? Okay, we will see why that is, right? Now look at this. So we'll go on with the heme iron first. Heme iron comes all the way here, comes to the proximal duodenum, right? Initial parts of the duodenum, right? And here, guys, there is on the apical side, right? Now, when you take this duodenal epithelial cell, this side is the basolateral side, and this side is the apical side, right? The brush border is the apex of the cell, apical side. So on the apical side, guys, there is a special transporter just for heme iron. Just for heme iron, this heme iron can easily pass and come here. What is the name of this transporter? What is the name of this transporter? Anyone knows? Anyone wants to guess? Shashank, want to guess? What is this? Just from the name, what do you all think it is?
Iron receptor.
Receptor. No, let's modify it a little bit more. Heme ion transporter. Okay, very easy, no? Heme ion transporter. This is called the heme ion transporter, right? Okay. So directly when heme ion comes, especially this ferrous form coming in, right, can be directly taken up into the duodenal epithelial cell, duodenal mucosal epithelial cell. Now, what about this ferric ion, the Fe3 plus coming in? This is a little bit of a problem, guys, because our duodenal mucosal epithelial cell does not have a channel to directly transport the ferric forms, the Fe3 plus forms, the inorganic forms coming from plants, right? Because of that, on the duodenal epithelial mucosal side, on the apical side itself, there is I will draw it here on these epithelial cells because I don't want to use that our big epithelial cell. There is a special enzyme here, guys. There is a special enzyme here. What does this guy do, right? So we know Fe3 plus comes here, right? This enzyme will convert that Fe3 plus to Fe2 plus, right? What is this enzyme called? Just from the function, what do you think it's called? There are two names. What is the easy name? Sorry, Tarind, I did not hear you. Excellent, excellent. Just like the function, ferry reductase, right? Ferry reductase. This one, guys, there is another important name. That name is not important in this chapter, but under genetic diseases, they use that name instead of this ferry reductase. This is also called duodenal cytochrome B, right? Duodenal cytochrome B. Not important. If you all remember ferry reductase for this chapter, more than enough, right? That's all we need to know. It does the reduction function, Fe3 plus to Fe2 plus, right? Now, this ion that was converted from Fe3 plus to Fe2 plus, guys, it has its own channel that can easily transport it, right? Come here like this. This channel is called what, guys? This is called, write this down, divalent metal transporter type 1, DMT1, right? Divalent metal transporter type 1, okay? DMT1. So already we have talked about 2 transport channel and 1 enzyme, okay? 1 enzyme, right? Okay. Up to here, is everyone clear? Now what has happened? The iron that we took in the diet has reached our duodenal mucosal epithelial cell. And in this cell, the iron is in what form? At the moment, in what form is it? It's in ferrous form, right? Ferrous form, okay? Right. Right? Okay. So this is why we say, guys, this is why we say the plant-based iron is not easily absorbed. Why? Any problem with the duodenal cytochrome B or the ferry reductase, what will happen? Absorption easily dropped, right? Whereas the heme ion, the Fe2 plus heme ion has its own transporter. It can easily take that in, right? Not an issue.
Shan,
Right?
can the Fe3 plus reduced to Fe2 plus can it also go through the heme iron transporter? Or
No,
is it
it
more
doesn't.
specific?
It doesn't go to the heme ion transporter because the Fe2 plus, the ferrous coming with it usually comes with the heme groups. So when you take animal foods, guys, right, it will be either the animal's blood, right, the hemoglobin, right. When you are eating, it will be a little bit of the animal's blood through it's cooked. I'm talking about cooked, well cooked food, right. But there is some blood, and then what do you eat? You basically eat muscle, right? We basically eat muscle, so myoglobin, right? So both of these can come in. They come with their own protein structure. So for the hemoglobin, it will come with the heme group and the iron attached in the middle and the globin chains. You're eating all of that, right? So that heme ion transporter transports that entire molecule, right? Whereas, so we are talking about the iron form there. It's in Fe2 plus form, right? So the ones coming from the plant, it will be converted and it will go through DMT1, right? It doesn't go through the heme ion transporter like that. Okay. Right. So up to that point, all good, yeah? Right. Now we will see what happens next, right? Look at this, guys. This iron that came to the duodenal epithelial cell now needs to come into the blood, right? Now needs to come into the blood, right? So there is another barrier. The first barrier was entering the cell. For this purpose, guys, for this purpose, Fe2 plus has its own channel on the basolateral side. Here, on the basolateral side, there is another channel to transport this, right? This channel, guys, we call it ferroportin. Ferro, P-O-R-T-I-N, not protein, ferroportin, right? Ferroportin, okay? Ferroportin. What happens, guys, as necessitated by the body, right? Because there is always an iron balance going on. We'll come to that towards the end, right? As necessitated by the body, the required amount, whatever is required by the body, will come from this duodenal epithelial cell into the blood vessels, right? Into the blood vessels, they will come. Okay, directly. They can just directly travel, not into the blood vessel, guys. Just give me a second. They will come here outside, right? Outside. Still not in the blood vessel. Just stop the arrow there, right? Whatever is necessary will come out, okay, through this ferroportin, right? Then let's say before we go into the blood, let's say now the blood already has enough of iron, right? The blood already has enough of iron. So what do you think the signal needs to be? To bring in more iron from the duodenum or to stop and hold on for a bit? Obviously to stop for a while, right? Because of that, these duodenal epithelial cells also have a minor storage function of iron, right? Minor storage function. How does that happen? These duodenal epithelial cells, guys, this is their nucleus, right? This is the nucleus of the duodenal epithelial cell. They can code for a special protein, right? There are some genes involved, right? They will produce the mRNA, they will get the signal. Okay, we don't need iron at the moment, store it for a while. So they will start transcription, translation, all that processes. They will produce this special protein, right? You can draw it like this, something like this, right? A protein. This protein is called what? This protein is called apoferritin, right? Apoferritin. Apoferritin, right? Apoferritin. What will apoferritin do, guys? It will capture whenever needed, right? Whenever the body gets the signal, okay, do the storage function for a while. We don't need iron right now. What will happen? Apoferritin produced. Apoferritin can capture some of these iron, right? Some of these iron and store them, right? Store them within themselves. Now, here's the important thing, guys. Apoferritin reacts with the Fe2 plus form, ferrous form, right? But when it's storing the iron, it stores it in this blue form, in the ferric form, right? Very important to understand. Okay, apoferritin takes the ferrous iron, and then there are some reactions going on inside. We don't need to go to that biochemistry level, but just know it stores it in the Fe3 plus form. Now, apoferritin, once it takes up the iron, what do we call it? What do we call it? Yes, you remove the apo part. You remove the apo part. This is now called ferritin, right? Ferritin, right? Apoferritin, once it is loaded with iron, we call it ferritin. Just remember, this iron is in ferric form. Ferric, okay? The blue form, right? The reactions going on there, not needed to know. Basically, what happens is, guys, it takes the ferrous iron, then reacts it with various oxygen species, and it adds some phosphates. The end product is called ferric hydroxide phosphate. Not necessary to know, right? Anyway, that is a ferric form. Ferric form. That much, if you all remember, that's enough, right? Right. So now in this ferritin, it will, what did we say are the two storage forms of iron? Ferritin and hemosiderin. So this is one of them, ferritin. So now, because the duodenal mucosal cell got the signal to not load more and more iron into the circulation, it did this storage function, and a little bit of ferritin is stored here. Now tell me this. Now, knowing all of this information, remember we talked about iron loss daily in both males and females. One of the methods we talked about was through feces. Now, can you all draw a correlation as to why that is happening? Why you're losing iron through feces? Why? Because of this, you all know our gut intestinal mucosa, guys, almost every 3 to 4 days, you're regenerating, you're producing new gut cells, right? Mucosal cells. So what is happening? These mucosal epithelial cells are sloughing off, right? At the end of their life cycle, they die and they slough off into the feces, right? So at that time, you can have some ferritin stored in those cells and you're losing those ferritin. That's how you're losing through fecal matter. Okay, right? Right. Now we'll continue with the iron that left the duodenal epithelial cell. We'll come back to this place, right? Now look at this, guys. Now the iron that left here is in what form? This is in ferrous form, Fe2 plus form, Fe2 plus form. But now there is another problem, right? Fe2 plus form or the ferrous form cannot be easily transported in the blood, right? For the transportation purpose, our body prefers the ferric form, Fe3 plus form. So what should happen? What should happen? What should be here? What should be here on the basolateral membrane of the duodenal epithelial cell? What should be here?
Oxidize.
Simple. An oxidating enzyme, right? Exactly what it is. There is another enzyme here on the basolateral surface, right? That will take this ferrous ion, right, and oxidize it into the ferric form, Fe3 plus form, Fe3 plus form, right? Fe3 plus form. What is the name of this enzyme? What is the name of this?
Ferrooxidase.
Excellent. Yes, correct. Ferrooxidase, ferrooxidase, correct. The if you want another, there is another name, right? Not necessary for today's class. If you remember ferrooxidase, that's enough, right? Ferrooxidase, and this one, guys, the proper or the name that they denote it is hefacitin, hefacitin, right? Not very important, right? If you all remember ferrooxidase, that's all I want you all to know, right? Hefacitin, okay? PHAE, guys, PHAE, yeah, PHAE, yeah, hefacitin, right? Hefacitin, right? Clear? Okay. So now what have we done? Now look at this, guys. What is our body doing? First converting, first reducing it from Fe3 plus to Fe2 plus to absorb. Then again converting it to the other side. Why? That is the only way. We don't know why exactly. That is, you can call it evolution, design, whatever. But for absorption, our body prefers Fe2 plus, right? Absorption from the gut into the mucosal epithelial cell. Then from the mucosal epithelial cell to the blood, and the transport part, for the transport part of iron, our body prefers the ferric form, Fe3 plus form, right? We will see why. Look at this, guys. Fe3 plus. Look at this. Fe3 plus. Do you think Fe3 plus should be allowed or can be allowed to just travel along the blood with the waves, with the flow? Why not? Why not? Why not? Why do you think? This is Fe3 plus. This Fe3 plus, guys, highly reactive, right? It can go and damage cell membranes. It can go and destroy DNA structures, give rise to mutations, right? It can do a vast, it can destroy cytosolic proteins, right? So ferric form is not allowed to be transported, should not be allowed to be transported freely in blood. Therefore, guys, what happens? Somewhere here, you all can draw a small liver. Somewhere here. In the liver, guys, we have another transport protein being produced, right? This protein looks something like this, guys. W, you all can draw like a letter W, right? This special transport, this is like a car, right? It's a car. This one is constantly being produced by the liver, right? It looks like this, right? These ones, guys, are called what? Transferrin. Transferrin. Okay, transferrin. Okay, produced by the liver. Produced by the liver. Transferrin has a nice affinity to Fe3 plus as opposed to Fe2 plus, right? This is why our body prefers to take Fe3 plus, because transferrin has a better affinity to Fe3 plus compared to Fe2 plus, right? Look at this. This transferrin, guys, why I drew it like this W shape? Each transferrin molecule, right, can bind with two, you can put two stars, right? There are two seats. It's like a sports car, two-seater, right? Only the front two seats. So it can, each transferrin molecule can accommodate two Fe3 plus ions, right? Two Fe3 plus ions. Okay, right? And once the Fe3 plus, the ferric ion, is bound to transferrin, it can transport all over the body safely, no problem. They will not go and harm any other structure, membrane bound structure or whatever, DNA or whatever, right? Now, here's the important thing I want you all to know here. Transferrin, guys, right? Transferrin, write this down. It is usually produced in abundance more than what is required by the body. Why is that? Why is that? Can you all just imagine? I'm giving you all a statement. Transferrin is produced in excess, right? Then, so for example, if I'm telling, now I'm eating some chicken, right? And I'm going to an atomic level. This is impossible to say, but just to make things clear, I'm eating a piece of chicken. I'm saying I'm getting 50, what do you call, ferric ions from this chicken, right? Coming into this place. But my liver is producing at that same time, right, more than 3 times, more than 150 transferrin molecules, right? More than 150 transferrin molecules are being produced. Why is this? Why is our liver always producing extra transferrin?
So that there is no excess Fe3 plus, and like if there is an excess Fe3 plus, it will cause damage.
Excellent, excellent. To bind to as much Fe3 plus as possible, right? Our liver is basically taking a safe bet. Then, so if it knows 50 Fe3 pluses are coming, what can the liver do? Easily produce 50 transferrin molecules and let them bind, right? Actually, we need only 25 transferrin molecules because one can bind with two, right? But what does the liver do? It produces in excess just to make sure none of the Fe3 pluses are left alone, right? Whatever Fe3 plus comes out through the ferroportin, right? Fe2 plus comes and then it is converted by the ferrioxidase there. Whatever is converted must be bound by transferrin, right? Otherwise, there can be issues, right? Right. So because of this, here there is an important ratio for you all to understand, guys, right? For every 3 transferrin molecules, this is roughly, you can put a roughly sign, for every 3 transferrin molecules coming into the circulation, right? Only one will be loaded with iron, right? Okay. For every 3 coming in, only 3 transferrins in the blood, one will be loaded with iron. So if I ask you, what is the percentage saturation of iron? Percentage saturation of transferrin. What is this, guys? This is about 1 in 3. If you take the percentage, this is about 33%, right? Roughly, right? About 33%. Now you all know hematology, guys, all of the values are in ranges. All of them are in ranges. So if you look at the laboratory range for this, guys, we usually say the normal range is 20 to 50%. Okay, 20 to 50% is the normal range. I'm giving you all the 33%. Just for the calculation to make it clearer. But the normal range is 20 to 50%. Within that range, our transferrin is usually, that is the percentage saturation of transferrin, right? Okay. Right. Now, just we are going into this later, but just from this information, can someone tell me this? If I tell you, okay, I have a patient. When I look at his iron profile, the percentage saturation of transferrin is very low, about 15%. What do I want you all to think about? What should come to your mind? Huh? What is happening in that person now at that very moment?
You don't have enough iron.
Yes, not enough iron that has been loaded onto the transferrin. Okay, not enough iron has been loaded onto the transferrin, right? If you all understand that much, for now, more than enough. We'll come to this later. Right? Right. Now look at this, guys. Another important thing here. There are some terms here also. Transferrin that is loaded with iron. Let me draw it like this. We will draw it, guys, just to make it clear, right? Take a side of your page and draw this. What is this? I'm going to draw it like this. Plus this. Can someone name this molecule to me? Okay, I will draw the finishing product also. Gives what? This. What is this molecule? What is this molecule? It's actually, you can draw a red one here. It's better to draw the red one here. What is this? This is like Montessori. I'm teaching you all, very important to understand these concepts. Once you get these, guys, iron profile is, when you see the iron profile, it will come to your mind. What is the diagnosis? What is this? Prashan? Ferritin. What are the two that have been added together? What are these two?
Ferritin and the Fe2 plus.
Fe2 plus. Apoferritin and Fe2 plus gives the ferritin. Another one that we just drew. This one, right? Plus this one. Let's draw two of them. Gives what? Something like this. Right? What is this? What is this resultant product? Okay. First tell me, what is this one? What is this one? The one I put a square around. What are these? Transferrin plus what? Transferrin plus what?
2 ferric ions.
Yeah, 2 ferric ions gives rises to this combination, guys. The loaded transferrin. What we call this is serum iron, right? The name here is serum iron. So whenever the iron profile says serum iron, what are they talking about? Iron that has been loaded onto transferrin. Okay, iron that has been loaded onto transferrin. This is called serum iron, right? This one is called ferritin. Right? This term is important, right? Okay. Then, guys, now we talked about the percentage saturation of iron as well, right? Percentage saturation means out of all the transferrins, how much is loaded with iron, right? Out of all the transferrins, we said in a normal person, around 20 to 50% of the transferrins are loaded with iron, right? The remaining are just there because we know the liver is producing more than required amounts of transferrin, right? Now, so what two types of transferrins do we know? One is a free transferrin. The other one is a bound transferrin, bound with, or saturated, you can say, bound with iron. These are the two types of transferrin you can see in a person's blood. Both of these together, when you add them together, guys, right, we get what we call the total iron binding capacity. Total iron binding capacity, TIBC. What is this? Iron bound transferrin and free transferrin together is called the total iron binding capacity. It is basically how much our body transferrin can bind, right? That's why it's a capacity, right? With iron. Okay. Right. Now look at this. I'm asking you all the question. Answer this, right? I'm saying in a normal person, right? The serum iron is about 100 microgram per deciliter of blood. About 100 microgram per deciliter of blood. Now looking at this percentage saturations in a normal person, let's take this 33%, right? Can you all tell me, what do you all think? So 1/3, 1/3. If the normal person's serum iron is about 100 micrograms per deciliter, can you all tell me what is his TIBC? Roughly, about what? About what?
300.
Excellent, excellent, right? Around 300 microgram per deciliter. Okay, okay. Did everyone understand? Very fine point, very important to understand. If you all don't get that, difficult to understand the iron profile. Okay, understood. Give me a thumbs up. Let me see your faces. All good, right? Okay, right. Okay. Now, so we are almost done with the absorption part, right? We'll write this down. Just one more point to add here, right? Okay. Look at this, guys. One more function, rather, of this duodenal epithelial cells. What did we say? Duodenal epithelial cells, as required, whenever they get the signal, right? They can either help storage of the iron within themselves, or they will push them via the ferroportin out into the blood, right? That is what their function is there. Here, guys, another important thing, these duodenal epithelial cells are in very close proximity to our vessels. That's why I drew the vessel just close by, right? They have some special receptors, guys. We are not going to draw the atomic forms of these receptors, very complex structures. Not necessary. We'll just draw them as eyeballs, right? Just eyes looking at the blood. They're like eyes. They're looking at the blood. Okay, you can draw eyelashes or whatever in your free time, right? Now, these are, guys, iron sensors. Our duodenal epithelial cells have some iron sensors, guys, right? These are nothing else, not any mechanical eye placed there. They're just receptors. They're just receptors, and they are sensitive. They can sense the circulation's iron concentrations, right? They are iron sensors. What they do is, guys, these iron sensors are constantly active, always sampling the blood, looking at how much iron is there, right? And they send direct signals to the nucleus as required, right? They can send direct signals to the nucleus as required. So tell me this. Now I'm telling you, I have a patient in iron deficiency, and we still didn't talk about what happens exactly in iron deficiency, but I will tell you for now. The serum iron is a little bit low. In this patient's blood, iron concentrations are low, right? What sort of a signal do you think iron sensors gives to the nucleus? Produce more apoferritin or inhibit the production of apoferritin? What do you think? Inhibit the production of apoferritin. Because why? If the circulation is having less iron, we don't want to store more. We want to take as much iron from the GIT into the blood, right? So that is the function of these iron sensors. They sense the amount of iron, right? And based on the state of the body, right, they will give signals to either stimulate or inhibit apoferritin production. Stimulate or inhibit apoferritin production. Okay, right, right. Then one more molecule we need to talk about here, guys. From the liver itself, right, we have this other molecule being produced. You can draw it something like this, right? It's also a protein, right? This is called, guys, hepcidin, right? Hepcidin, right? Hepcidin, right? Hepcidin, guys, a few points to note under hepcidin, right? First thing I want you all to know, hepcidin, again, it is produced by the liver. It is synthesized by the liver in response or based on the iron amount in the circulation. What do I mean by that? One thing, if iron is too high in the body, if iron is too high in the body, this is directly proportional. Hepcidin synthesis will increase. Hepcidin synthesis will increase. What does hepcidin do, guys? It has the power to inhibit all three transporters that we talked about. It can inhibit divalent metal transporter 1. It can inhibit the heme iron transporter, right? And it can inhibit ferroportin, right? Hepcidin has the power to inhibit all of these three, right? Okay. Then another important point about hepcidin I want you all to know, guys. Hepcidin is increased in certain other conditions as well. For example, inflammation. Inflammation, if the patient is having some bodily inflammation, right? Because this hepcidin acts as an acute phase reactant. At the same time, in certain malignancies, also hepcidin increases, right? So just know hepcidin increases, right? Again, what happens when hepcidin increase? Divalent metal transporter 1, heme iron transporter, ferroportin, all can be inhibited. Therefore, what happens to the overall absorption of iron from the GIT into the blood? Whenever hepcidin is high, iron absorption drops, right? Whenever hepcidin is high, iron absorption drops, right? Then, what do you think happens in a patient with severe anemia? What do you think happens to hepcidin in a patient with severe anemia?
Decreases severely.
Sorry?
Decreases.
Decreases. Hepcidin decreases. Why? So we don't want to inhibit those channels. Then we want to take as much iron as possible. So we don't want to inhibit those channels. Right. Now, just from this hepcidin, we will discuss again when we come to the treatment part in depth. Tell me this. I have a patient, right? I have a patient coming in with iron deficiency anemia, and I will teach the treatment. I'm just going there, right? I have put the patient on some iron supplementation, right? He does not have any parasitic disease or any other gastrointestinal related disease that has been diagnosed. But no matter how much iron I give, right, his iron profile always shows less numbers, right? His iron profile does not show any improvement, right? Okay, and the patient has some photosensitive rashes. What do you think is the problem with this patient? Maybe a small something like SLEY, a chronic inflammatory disease, right? What did we say? Whenever inflammation is there, hepcidin is high. When hepcidin is high, all these receptors are going to be dysfunctional. So even if you give them iron supplementation orally, maybe they don't show an improvement. Okay, these are things to think about. Okay, we will talk about this later when we come to treatment, right? So in that case, if oral iron supplementation is not working, what can we go for? IV iron. I will teach you. Right, let's move on. Right. So that's about it for the absorption phase. Just put a table, guys. Factors stimulating absorption and factors inhibiting absorption. Right? What are these factors? Let's just make a quick table, right? Look at this. First of all, when you look at the food products, guys, food products, right? Just write these down. We'll go quickly. Food products. What do we have? We have, guys, certain things called phytates and tannates. These phytates, guys, we find in cereals, in certain vegetables, right? Legumes, right? These kind of stuff, right? And tannates we find in tea, tannic acid, coffees, right? Black teas, right? These kind of things. Some we find a little bit in theophylline as well, right? And then we have various other things, phosphates, oxalates, right? Not necessary, guys. Oxalates, these kinds of things, right? Oxalates, you all know they come in oxalic acid, these tomatoes, spinach, these kinds of things, huh? Right? These kinds of things. Guys, my bad, huh? Inhibit on this side, inhibit absorption and put plus here, huh? Sorry, huh? These things inhibit absorption, huh? Phytates, tannates, phosphates, oxalates, all of these inhibit, okay? Right? Then, tell me this second one, hepcidin increase. What can it do again? Inhibits iron absorption, right? Next one, guys, any defect or a reduction, you can say defect or reduction, right, in any of the transporters, in any transport. So it can be any genetic defect, right? Any of the transporter proteins, right? DMT1, ferroportin, heme ion transporter, anything, right? It can also cause reduction in absorption, right? Then tell me this one, hypoxic states. Hypoxic, no, we'll leave that for a bit. I will tell you all why. Okay. Right, this number 4, alkalis. Right? Especially, guys, medications that is increasing alkalinity of your GI tract. I will tell you why when we go to the absorption positive side, the other side, right? Just write here alkali, right? It can alkalis inhibit absorption, right? Then put a star here for the 5th one, calcium, right? Now this one, guys, relatively recently found, right? Calcium has an inhibitory effect on iron absorption. That one, of course, we knew for a while. But what was relatively recently found was this calcium inhibits both inorganic and heme form absorption, right? Both of these are inhibited from calcium. Whereas these other food products, guys, the phytates, tannates, phosphates, oxalates that we talked about, majority, it causes heme ion absorption reduction. The inorganic, the plant-based one, still not a big problem here, right? That can be easily absorbed. I know it's only 1 to 2%, but it will be absorbed. The heme ion majority one is stopped here by these other food products. Calcium, on the other hand, right, inhibits both, right? Okay, especially, guys, not your daily dietary intake of calcium. Here, basically, what we are talking about are supplements, guys. Supplements, right? All these Calcivita, Calmax, 5,000 mg a day, right? For these arthritis patients and all, we prescribe these things. These kind of ones, yes, it can cause some deficiency in iron, okay, due to reduction in absorption, right? Right. We'll come to this one. Substances or influences that promote the absorption. What are we talking about here? First thing I want you all to know, right? Food products, right? Acids, guys, ascorbic acid, especially ascorbic acid. What is ascorbic acid? Vitamin C, vitamin C, right? What this does is, guys, how this helps in absorption, not necessary to know, but basically what it does is it forms a chelate with Fe3+, right? And that chelate is very soluble, right? It helps the Fe3+ be very soluble. So it helps in the conversion of Fe3+ to Fe2+, which is essential in our initial stage of absorption from the apical side. Remember, we want to always convert it to Fe2+, right? So that's why ascorbic acid helps. Then apart from that, we have various sugars, amino acids, right? Amino acids, these dextran sugars, right? Not very important to know, just keep those down. Hepcidin reduction. Hepcidin reduction again promotes absorption, right? Then any increase in activity of the transporters, increased activity or increased expression, right, of the transporters. What are the transporters? DMT1, ferroportin, heme transporter, all of that, right? Right. Then guys, acidic environments. Acidic environments. This is basically we are talking about low pH, right? In low pH, guys, right? This conversion of Fe3 plus to Fe2 plus happens rapidly, right? Okay. Reduction of iron happens rapidly at lower pHs, right? Now tell me this, based on this acidic and alkali situation here, right? What sort of drugs might be affecting a person to develop iron deficiency anemia?
Proton pump inhibitors.
Excellent. PPIs, right? Proton pump inhibitors, and the other, what is the other potent one? Histamine, H2 receptor blockers, cimetidine, ranitidine, these things, right? So when you give these things, you have to make sure the patient does not have a history of iron deficiency or something like that. Or if they are having something like severe reflux disease, gastroesophageal reflux, what should you do? You can't stop the proton pump inhibitors, but what can you do? Put them on iron supplementation. Okay, right? We'll talk about those again in the treatment. Then guys, just put another one here, another star here, right? During increased demand, guys, for example, our pregnancy period, or if the patient is having iron deficiency, right? During these times, right? What did we say? There are iron sensors on our duodenal epithelial cells, right? Those will see that the blood has less and less iron, and they will send signals, right? Inhibiting apoferritin, and therefore the storage function will reduce, absorption functions increase. Okay, right? During pregnancy, lactation not as much, but pregnancy is the main one, and during iron deficiency itself. Okay, right? Everyone understood up to this? All good, right? So this is the absorption phase. Now we are going into the other two phases, not as much. Look at this. We are not going too much into this. Second phase, utilization. Basically, what are we talking about here, guys? Hemoglobin synthesis, right? Right? These are very in-depth discussion, right? We don't need to go all that for iron deficiency, right? We'll go through some basics. Look at this. Where did we stop now? We stopped at this blood vessel. Take a new page. Put that same blood vessel there. And what did we have? We had our transferrins that have been bound with iron. Some of them, right? About 33%, about 20 to 50% of them, right? This is where we stopped last, right? What happens to this? Now, hemoglobin synthesis mainly happens where? Bone marrow, right? So this travels, guys, along the circulation. It will travel to our bone marrow, right? I will draw something like this. Specifically, guys, during erythropoiesis, we have this type of cell called the erythroblast, right? Specifically here, our transferrin will travel all the way to the bone marrow and reach this erythroblast. Now we'll take a zoomed in view of this erythroblast to see what is happening. So you all can draw a large erythroblast somewhere here. Right? This is an erythroblast, right? Erythroblast, guys. Erythroblast, it has the receptors. something like this for the transferrin molecule. These are transferrin receptors. So what will happen? Transferrin with that ion will come and bind here, right? Transferrin with the ferric ion, the blue ferric ion will come and bind here, right? Right. What will happen? Endocytotic process will happen. It will take this in, right? And it will put it into a small vacuole sort of thing, something like that. And I will draw it there, right? And now what do we have here? We have the receptor. We have the transferrin molecule. And we have the two Fe3 plus ions. Fe3 plus ions, right? Something like this, right? Okay. Right. What happens, guys? You all know after an activity like this. What happens? These receptors, right? The transferrin and the transferrin receptor will both be thrown out. These will be thrown out back, right? You all know the transferrin receptor will be re-expressed here, right? And the transferrin will be brought back into the blood to bring more iron. So what is remaining here? Our ferric ions. Ferric ions will remain in this, right? Ferric ions will be remaining there, right? The receptor will be re-expressed on the erythroblast and the transferrin will be put back into the blood, right? To bring more iron, right? Now, look at this. Hemoglobin, we saw in the animal meats as well, right? So now we are talking about human hemoglobin, in this case, in our body, what is happening. So our hemoglobin has what form of ion, guys? Ferric form or ferrous form? Ferric or ferrous? Ferrous, right? We are not very different from other animals. We are also animals, right? So we also have ferrous form, right? So look at this. Now inside this erythroblast, the ion that was brought in is still in ferric form. So what should happen? There should again be another enzyme somewhere here, right? Okay, to do what? Right? To make it into the ferrous form. That is exactly what it is, guys. The ion name, the enzyme name is a little bit different, right? It's a ferri reductase again, because we are converting 3 plus to 2 plus. But what we call this, guys, endosomal ferri reductase. Ferri reductase, right? Endosomal ferri reductase. For those who want to read extra at home, right? This one, guys, it's given a special name basically from its gene, right? STEAP3. If you all want extra, you all can go and read if you all want. These are yield for not for exams, guys. Not for exams. These are for research things, right? Right. So endosomal ferrireductase, what will it do? It will convert these into ferrous, right? Two ferrous ions there, right? Ferrous ions there, right? Then what happens, guys? Tell me, in the GIT, once the ferrireductase worked, what channel did the GIT use to transport the newly reduced ion, the ferrous form? What did we use? Okay, that is on the basolateral side. On the apical side, after the ferrireductase work, what did we use?
Divalent.
Excellent. DMT1, divalent methyltransporter 1. Same channel is here. DMT1. So out of this endosome or this lysosomal structure, what happens? This guy can now come out, right? It will come out and we will incorporate that into heme. Now, before incorporating that into heme, we have to look at what else was going on in the erythroblast to produce the structure. Look at this. On this side of the erythroblast, guys, you can draw a mitochondrion. Inside the mitochondrion, there are some reactions. Inside the mitochondrion and in the cytoplasm itself, there are some reactions going on. Let's see what is happening. Firstly, guys, don't worry. These names, don't worry. Look at this. There is something called succinyl-CoA. Succinyl-CoA. We are not going to go full on biochemistry. Succinyl-CoA reacts with something called glycine, right, to give rise to what we call ALA, amino levulonic acid, right? Amino levulonic acid. Don't worry, these are just words. Amino levulonic acid. Two ALA molecules, ALA plus another ALA, will join together, come to the cytoplasm to form what we call a pyrrole, right? It looks something like this, guys. Let me draw it in a different color. I'll draw it in pink, right? To form what we call a pyrrole, right? Pyrrole molecule, right? Pyrrole, guys, 4 such pyrrole molecules, 4 pyrroles, right? 4 pyrroles get together, right, to form what we call, look at this structure. Draw it like this, This is a pyrrole, 4 pyrroles getting together, right? 4 pyrroles getting together. We call this protoporphyrin. Protoporphyrin. Protoporphyrin ring. We call this a protoporphyrin ring. Okay. Protoporphyrin ring. Right? Okay. The protoporphyrin ring, guys, right? Let me draw it like this. Comes back here, right? Comes back here into the mitochondrion, where it is loaded with the iron, right? So it will look now something like this. Right? And an iron in the middle, right? You all can draw that iron, this iron, right? Will be put in the middle like this. What is this? The protoporphyrin ring with iron in the middle. Fe2 plus iron in the middle. Ferrous iron. What is this?
Hemoglobin.
Heme, not yet oglobin, not yet oglobin. We'll add the oglobin now, right? This is heme. This is heme, right? Heme, right? Then that is the next stage, right? This comes out of the mitochondrion and from our erythroblast nucleus, right? It produces, it codes for these proteins called globins, right? There are different types: alpha globin, beta globin, delta, theta, right? There are a lot of different types of globins. Specifically, we'll talk about those tomorrow in thalassemia. That's where we talk about all the different types of globin chains, right? What is happening, guys? To this structure, globin chains will be added. Something like this. A globin chain, something like this, right? Will be added, right? Globin chain will be added. 4 of such molecules, guys, you all know, right? Such molecules, right? We have 4 heme groups with their globin chains, right? Which are usually 2 alpha and 2 beta globins. 2 alpha and 2 beta globins, right? 4 globin chains and 4 heme molecules together. What do they form? Hemoglobin. That also we have the hemoglobin A, right? Hemoglobin 0. We'll talk about all of that tomorrow in thalassemia. For now, all I want you all to know is this hemoglobin synthesis. This is all we need for this iron deficiency anemia, right? So this is how the iron is utilized, guys. Now this hemoglobin will be used for what? Hemoglobin will be used for what? It will be used for erythropoiesis. Erythropoiesis. Right? Erythropoiesis. Right? I have put a diagram, guys, in your skeletal note. Here, look at this. Here, right? See, somewhere around the late erythroblast to this normoblast phase. During this time is when you can see the cell transitions from like a blue sort of color to a more pink sort of color. Why? Hemoglobin is now being produced and hemoglobin is being accumulated in the RBC, right? Okay, so that is that phase, right? So let's say we have made an RBC, right? We have made a nice RBC, right? Right, something like that. That RBC will come into the blood, right? Come into the blood. What is the lifespan of an RBC, guys?
3 months.
Yeah, about 120 days. About 120 days, right? So this will be in circulation for about 120 days, right? 120 days. After, when it's nearing its the end of its lifespan, we know, guys, these RBCs, they need to be destroyed. Guys, okay, tell me this. Why can't RBCs live more than 120 days? Why? Just the simple reason.
Nucleus is not.
Excellent. No nucleus to repair itself, because you all know RBCs have to squeeze through tiny blood vessels. They constantly get damaged. There is no nucleus to produce new proteins to heal itself, right? To synthesize new membrane substances. So by the end of 120 days, they are literally dysfunctional. They're useless in the body, right? So they need to be destroyed. That is what is exactly going to happen. They will be taken up by especially our spleen, right? The macrophages in our spleen and some macrophages in our hepatocytes and other reticular endothelial cells, right? So we will draw a large macrophage here. They will be taken up by macrophages, right? They will be taken up by macrophages to be destroyed at the end of their lifespan, right? At the end of their lifespan. What is happening here, guys? Let's say the RBC was engulfed, right? Taken up by this macrophage. RBC will be now broken down. Let's look at this. We'll draw an RBC, we'll break it down. One part is the membrane components. Another part, cytoplasmic components. And another part is the hemoglobin. These, we are just talking about how the RBC is being broken down in the macrophages, right? Just the basic run through. You all know the membrane and the cytoplasm. So especially the membrane, we know it's phospholipids, right? So we have some lipids being produced here during the breakdown that will eventually form fatty acids, right? Any proteins in the membrane will form amino acids, right? Cytoplasmic same, proteins in the cytoplasm will form amino acids, right? That those parts are not very necessary for us today. Hemoglobin, what is happening to this hemoglobin during the breakdown? Look at this, guys. Mainly breaking down into two parts, the heme part and the globin part, right? The globin means what, guys? These are proteins. These are protein chains, right? Globins are protein chains. Tomorrow we will discuss the structure of those more, right? Globin chains basically will go into amino acids. They will be broken down into amino acids. That also we are not that concerned about today. We are concerned about this heme part. Look at this, guys. During this process, the first thing that will happen, remember our protoporphyrin ring, guys? Remember this protoporphyrin ring? This ring, the ring form will be disintegrated. So what will happen? The first thing that will happen is this ring will disappear and now it will be something like this, just like a chain, right? Just like a chain, right? The ring disappeared, right? So it's just now 4 pyroles joined together. It's still not, it's now not a ring anymore. And when the ring structure disappears, what was in the center of the ring? Our Perera ion. So the ferrous ion will come out now, right? Fe2 plus will come out, right? Fe2 plus will come out. Okay, right. We'll leave that Fe2 plus there, right? We'll see what happens to it. Before that, look at this pyrrole structure, guys. This structure, this is what we now call biliverdin, right? Biliverdin, the opened up pyrrole ring. This is what we call biliverdin, biliverdin, right? This one, you all already know what happens. Biliverdin is put back into the blood, right? Where it will be taken by special transporters, right? We'll put a transporter here, a special transporter. And where will it go to? It will go to the liver. It will go to the liver. In the liver, what happens to biliverdin, guys? Don't worry, these things are not related to today's chapter. That's why I'm not going through all of them. Once we come to hemolysis and all of those, we'll talk about these in depth, right? Biliverdin converted to bilirubin. Bilirubin, we'll talk about conjugated bilirubin, unconjugated, we'll talk about all of those in the hemolysis chapters. And that will be eventually excreted, right? Excreted. So that one we are not again bothered about. Now what are we left with, guys? This fellow, right? Fe2 plus, right? We'll see what happens to him, right? Everyone understood up to this point, right? Everyone understood up to this point. This is the utilization phase. So basically what did we do? We took some of the iron that was bound to transferrin, right? Took them into the bone marrow, removed the transferrin and the receptors, everything, right? Reduced it into the ferrous ion, loaded it into the hemoglobin, into the protoporphyrin ring, forming the hemoglobin, put it in the red blood cell. This is all one process. Put it in the red blood cell. After 120 days, what happens? Disintegrated, right? Heme, we break down into heme and globin. Proteins are there. Heme forms the protoporphyrin ring will be disintegrated to form biliverdin, which will eventually be excreted as bilirubin. What we are left with is that Fe2 plus. Fe2 plus. Everyone good up to here? Give me a thumbs up. Right? Right. Then we come to the final stage, guys. Storage. Phase 3. Storage. Right? Storage. Now, we'll start off from where we stopped. Draw a large macrophage. Where did we stop? We had a macrophage. And you all can draw a blood vessel. Right? How did we stop? We had a ferrous ion. Fe2 plus ion. This is where we stopped. Right? This macrophage also, you can draw a nucleus. Macrophage has a nucleus. Right. Right? This is the macrophage. Now we have got a ferrous ion there. Right? Look at this, guys. This macrophage. Now, when we are talking about storage, what are the main storage forms of iron?
Ferritin and hemosiderin.
Ferritin and hemosiderin. Out of those two, also main one is ferritin, right? Now look at this. Can this Fe2 plus just be left inside of the macrophage and just ask them to stay there, Fe2 plus? No, right? Obviously, for storage, we need to convert them, right? What happens, guys? Again, like the duodenal epithelial mucosal cell, this nucleus of this macrophage, or be it the macrophages in the liver, be it the macrophages in the liver, Kupffer cells, right? Or be it the ones in the spleen, reticular endothelial system, wherever, they also can code for what? They can code for apoferritin, right? Now what do we know? Apoferritin together with Fe2 plus. What does it form? What does it form? Ferritin. Ferritin stores the iron in what form? Ferric form. Okay, ferric form. Right? So a lot like this will be there, guys, in our macrophages. So if we look at the iron stores in our body, macrophages are one of the main organelles or main cell types, that store iron, right? Multiple ferritins will be there. Now, one thing I want to be clear, guys. One molecule of ferritin can store how many Fe3 plus ions? I don't want to get you all to get the wrong idea from my drawing. That's why. Now here, what I drawn one star inside one circle. Actually, no, guys. Actually, one molecule of ferritin can store up to 4,500 to 5,000 molecules, right, of Fe in the Fe3 plus form. In the Fe3 plus form. How does it do it, guys? It crystallizes this, right? This is why we said it's called ferric hydroxide phosphate, right? It crystallizes them into tiny, tiny atoms and stores them compact, right? 4,500 to 5,000 per ferritin molecule, Just remember, it stores it in the ferric form, not ferrous. Okay. We will see why it is an advantage of it storing it in the ferric form. In a little bit, we'll see that also. Now look at this. Here. Now, according to the body's requirement, guys, right? Let's say the circulations iron is reducing a little. So if that is the case, what do we want? We want some iron being reduced from the stores to come into the blood, correct? If our body's iron is low, we want to take, that's why we are storing it, right? Why else would we store iron? We are storing it to take it whenever we need. So just know, guys, some of this iron, according to the body's requirement, these ferritin molecules can come into the blood, right? I will teach you all what happens once it comes into the blood. For now, let's leave it there. According to the body's requirement, they can come. The other thing, let's say now, okay, a lot of, let's say RBCs have been broken down. So all that heme and all the globin has been disintegrated. We are left with the iron. So let's say we have a lot of ferritin in our macrophage. In our macrophage, it's being overfull with ferritin, right? What happens then, guys? Our macrophage has a special mechanism. It doesn't just drop all that ferritin into the blood, saying, okay, I am full. Now you take the iron, right? It doesn't just drop all of those. What it does is, guys, you can draw another arrow somewhere this way, right? It starts accumulating all of these ferritins together, guys. So it will start looking something like this, right? It forms clusters of ferritin. Again, who is in the middle? These ions are in the middle, ferrics. All these ferrics are in the middle. These ones are larger molecules, guys. These are much larger molecules and they are insoluble, right? Larger, insoluble. This is what we call, guys, hemosiderin, right? Hemosiderin, right? So we have ferritin, and once these ferritins, they join together to form large insoluble molecules. These are what we call hemosiderin. This is another storage form of iron, right? Another storage form of iron. Majority is in ferritin state. If iron is a little bit too much in the body, it will start depositing them as hemosiderin, right? Then another important thing I want you all to know, now let's say, okay, now this macrophage has made some hemosiderin as well. But now the body's iron level drops a little. So what should he do? Should he keep them in the hemosiderin form? No, he should break them back down. That also, this is a reversible process, guys. These clumps, these clusters can be broken back down into the individual ferritin molecules, right? So just for the efficient storage, they will join together, form clusters and form the hemosiderin. Again, when required, they can disintegrate into ferritin, right? And what did we say about the ferritin? As required, ferritin can be easily coming into the blood, easily brought into the blood, right? Hemosiderin, guys, not that easily brought into the blood. And if hemosiderin is so much in excess, that it starts leaking into the blood, there is going to be a problem. We call this hemochromatosis. We'll talk about this later. Okay, hemochromatosis. We'll talk about that later. But the ferritin can be brought. No problem. Ferritin can be brought. Hemosiderin usually not brought, right? Unless there are some underlying pathologies, which we'll talk about later. Now, here's some important things. So what do we know about ferritin now? This is smaller, much smaller, and these are soluble, guys. That's why they can be brought into the circulation, right? They're soluble, right? And they are so small, you can see them only on electron microscopy. Hemosiderin, they are much larger. You can see them on light microscope. Only problem is you need to use this stain, guys. We call it Prussian blue. Prussian blue stain, right? Prussian blue stain, under light microscopy, you can see hemosiderin. That's how large they are. Okay, they are large. Okay. So usually, if this is not generally done, because there are enough and other ways to look at the iron in your body, but on very rare occasions, we can do a bone marrow biopsy to look at this hemosiderin, or to look at the macrophages, and to look at the stainable. We call this stainable iron, guys. Hemosiderin is called stainable iron. Okay, ferritin is non-stainable. It's electron microscopy, no. Only in dead cells you can see it, right? Hemosiderin is stainable iron, right? Right. Did everyone understand this? Right? Now look at this, guys. Now, when this ferritin is in the blood, in the iron profile, what do we call this? Serum ferritin. Right? And what did we say about ferritin? Ferritin can easily travel from the macrophage into the blood circulation, right? Unlike hemosiderin. Because of this, guys, very important point, listen carefully. Because of this, serum ferritin, we say, is a good indicator of our body's iron stores, right? Serum ferritin is a good indicator, or it's proportional to our body iron stores. What is the advantage of this information? If you suspect a patient is in iron deficiency, you don't need to cut open his spleen or do a spleen biopsy or a bone marrow biopsy and take samples out of that. You just take a blood sample, look at the serum ferritin. If it is low, it is highly likely that his body's iron stores are also low. Okay, right? Did everyone understand that point? Right? So serum ferritin is proportional to your body iron stores, is a good indicator, right? Right. Now tell me this. Answer quickly. I'm going to ask it quickly. Answer quickly. Serum ferritin and serum iron are the same thing. Correct or wrong? Excellent. What is serum iron? Transferrin bound with iron, right? Transferrin bound with iron. Okay, don't forget those, right? This iron profile, guys, at least for me, when I was studying in my 4th, 5th year, I always tend to mix up the things, right? One day fine, after a week, when I see serum iron, was it this or was it that? So just understand today, right? And keep it written down. Whenever you are going through it, just go through the naming. Right. Now, what else here? Right. Look at this, guys. Now, what did we say about this hemosiderin? I will just mention that also before we finish this part. Hemosiderin, what did we say? This one is the storage, another storage form of iron. It's in minority, right? Not majority. Majority is ferritin. And at the same time, it is insoluble. It is not usually allowed to come into the blood, right? So hemosiderin is our stainable iron. Now, what happens when hemosiderin becomes excess? Hemosiderin becomes excessive, right? When hemosiderin becomes excessive, guys, first thing, it will start accumulating, right, in parenchymal cells. Parenchymal cells. But still it is not too high that it causes damage, right? This is the period of time we call it hemosiderosis. Hemosiderosis. So in many of his organs, if you do biopsies, you can find hemosiderin accumulated. At the same time, in his blood, his hemosiderin will be high, but it is still not too high. The next condition, if we don't treat it, right, hemosiderin increases so much, right? That is when this will start causing organ damage, right? Beyond a certain value, beyond a certain threshold, it will start causing organ damage. Now, one of the primary places, guys, pancreas, right? Causing damage, it gives rise to diabetes, right? Now, in the initial stage, we'll say this is stage 1 and this is stage 2. In the stage 1, it can also accumulate in skin, guys, under the skin, just under the skin, giving a light bronze appearance. Then once the disease progresses further, it starts attacking organs, pancreas, liver. It can give rise to cirrhosis, right? It can even go to the heart, right? Hemosiderin deposits in the heart, right? Giving arising arrhythmias, all of those things. Here, this bronze color of the skin and diabetes, what do we call this? Bronze diabetes, bronze diabetes, right? This is severe hemochromatosis, right? Hemochromatosis, right? So hemosiderosis and hemochromatosis, two different situations. Hemosiderosis is the initial stage, right? Not much damage, no organ damage, just some accumulation. Especially if you do a biopsy, you will see it. Otherwise, no real manifestations apart from the slight discoloration of the skin. But as the disease progresses, what happens? We start manifesting. So you can write liver cirrhosis, right? Heart, cardiac arrhythmias, right? All of these can happen. Myocardial infarctions, cardiac arrhythmias, all of these, right? And the pancreas, yes, diabetes. So this is bronze diabetes. That is when we call it hemochromatosis. Okay. Right. Now, did everyone understand up to this point? All good, right? All good. Look at here. We'll do a quick summary, guys. What did we say up to now? Look at this summary, right? Just a basic one, just to, so this is our digestive tract, right? You all can draw this even at home. I'm just drawing it quickly, right? We said the blood vessel, we had a bone, right? And we had our macrophage, and we had our liver. All right, look at this, guys. What do I want you all to realize here? Look at this. We said from the digestive system, right? Some amount is going to be taken up by the circulation, right? Circulation. What did we say, right? That amount usually will be put into transferrin, and we know transferrin will take it all the way to the erythroblasts, right? From the erythroblasts, they will do the hematopoiesis, and the red blood cell will come here. After 120 days, what did we say? It will be taken up by the macrophage, right? Macrophage, and then it will be broken down, right? Hemoglobin will be broken down, and that iron part, whatever necessary, will be stored as ferritin, right? And whenever necessary, they can come back into the blood, right? Ferritin can come back into the blood, right? And some breakdown products here we said to the liver, right? All of these things, they will be excreted, bilirubin and all of that substances, right? And the liver plays a major role because it produces certain substances like transferrin and another substance called hepcidin, right? It plays a major role in control. Now, what do you see here? Look at this diagram that I just drew, right? Our body, guys, from our meals, it is taking a little bit of iron, But the rest, the major portion of iron in our body, what is happening? It's being recycled. Can you see? Majority of our iron in the body itself is being recycled. This is why, just because you don't eat meat or any iron containing foods for sometimes days, weeks, even months, you won't develop iron deficiency anemia. Why? Your body has enough stores to keep recycling the iron. Keep recycling the iron. Right? Okay. Now, what is the problem here? What do you think is the, okay, so I'm saying, okay, this is an advantage, right? You don't easily develop iron deficiency anemia. What is the problem? As a medical doctor, what do you think the problem is?
Can't identify a disease early.
Sorry?
Can't identify the disease early. That's the problem.
No, okay, not necessarily. So disease identification, it's like this. Usually these iron deficiency anemias are in communities, especially with food related, especially we say those days we said poorer countries, right? And then we say poorer communities, right? So so let's say you're a doctor and you're working in one of those areas, then you are likely to expect, okay, maybe there are a lot of cases of iron deficiency anemia possible. No, the problem I want you all to understand is this. It's not easy to get iron deficiency anemia because we have enough stores. But once you get it, not easy to completely recover, guys. It takes a long time of iron supplementation, right? I will teach this in the treatment, right? We can't just replenish our iron stores like this in a day. Huh? You can't take a few shots of IV iron. No, doesn't work, right? Not easy to get the disease. Once you get it, not easy to get rid of, right? It's a basic thing. We have only iron supplementation and a few other things to do, but the time duration, we have to usually treat 3 to 6 months sometimes, right? And if he's in a population of a high risk population community, right, where there is iron deficiency prevalent, then treatment can be even longer, 1 year, 2 years sometimes. Okay, so we'll talk about that in the treatment. This is what I want you all to understand. True, we take some little amount from the diet. That's why we said dietary absorption is very minimal, guys. If you take meat products, you all know a chicken breast has about 3 milligrams of elemental iron. Right? So we need how much? For a normal person, right? You all can write this down, guys. Write this down. Recommended nutrient intake of iron. RNI of iron. Right? RNI. Right? Write this down. Males or menopausal females. Menopausal females. Right? They need, guys, greater than, usually we say, just say 8 to 10 milligrams of iron a day. 8 to 10 milligrams of iron a day. Right? Then we have females of reproductive age. Females of reproductive age who are having their regular menses, right? They need 15 to 25 milligrams. These are per day, per day, right? Of iron, of elemental iron per day. And then, guys, just y'all can put a star. Pregnancy, we usually give iron supplementation. Iron supplementation, right? We usually give, guys, 100 milligrams. We give sulfate, right? FeSO4. This is the famous one. There are other ones, so I will teach you all in the treatment part. Gluconate is there. We'll talk about those, but mainly ferrous sulfate, right? We give this amount. That is pregnancy. That is different, right? A little bit of an exception. So see this, right? Males and menopausal females, we require about 8 to 10. Females require a little bit more. Full chicken breast, full large chicken breast piece will give you about 2 milligrams. And out of that 2 milligrams of iron, since it's meat product, how much do we absorb? How much is absorbable? Only 10 to 15%. How many chickens should you kill in a day to get that amount? If you want to take it only from the diet, that is the issue, right? We cannot kill that many chickens. I mean, that's not the issue. But what I'm trying to say, we cannot get all that we need from the diet, right? Major composition, major form of how we get iron is through this recycling. Okay, everyone understood that, right? Okay, right. Now, we'll look at the causes, guys. Causes of iron deficiency anemia, right? What are these causes? what causes iron deficiency anemia. So iron metabolism done. Huh? Now iron metabolism is done. Now you all know how we absorb, how we utilize. Now we'll see what causes iron deficiency anemia. Basically, we can break this down into 4 groups, guys. Write this down. 1, 2, 3, 4. Right? First one, reduced intake. Obvious, no? Reduced intake of iron. The second one, due to some causes, reduced absorption. So the intake is good, the meal is good. They are not from a poor region, right? But they have problems with absorption. We'll see what that is. Or we have increased demand. That's the next one, right? And the final one, increased losses, right? Increased losses. Look at this, guys. Reduced intake. What are we talking about here, right? You all can write down anything. Firstly, you all can write down poor regions, right? Third world countries, poor regions, right? Poor communities, right? If their diet, usually, guys, these poor people diet, right? You all know, first thing, they don't have a lot of heme, they don't eat a lot of meat, right? Because I mean, meat is expensive compared to plant-based products, right? And so plant-based products, what's the issue? They have iron, but only 1 to 2% absorbable, right? So that's one issue there. Then, guys, write this down. Infants on cow milk, right? This cow milk, guys, it has relatively more iron compared to human milk, breast milk, mother's breast milk. But the problem is it is not easily absorbed. Cow's milk is not easily absorbed. The iron in cow's milk is not easily absorbed. Okay, right? So infants purely on cow milk, right? Formulas, right? They tend to absorb less. Next one, elderly people, guys. Elderly persons, right? This we call, guys, have you all heard this tea and toast diet? Tea and toast diet. What is this tea and toast, guys? You all know, very old people, especially in their 70s, 80s, they have lost a lot of their teeth, no, guys? So they don't like to eat a lot of meat, a lot of vegetables like the strong spinach and all. They dislike eating these, right? Because they don't have teeth and it's difficult, right? So they prefer to eat this tea and toast diet, right? Paan kalla toast karan, right? Okay, a piece of bread, they will just toast it and take a plain tea in the other hand, eat it. That's their dinner, right? So this is easy for them. The issue is what? First thing, very little supply of iron and all, and at the same time, tea. What does it have? The tannates we talked about, right? Especially in teas and coffees, right? Further reduction, right? In iron in the body, right? Usually because of the dentition problems, no teeth. That's the main issue, right? Okay. Then reduced. So those are the main reasons for reduced intake. Then reduced absorption, guys. Again, we talked about all of those phytates, tannates, right? All of those food materials, you can put it in this section. Some things we didn't discuss, guys. A disease called tropical sprue. Tropical sprue. What is this tropical sprue, guys? It is a gastrointestinal disturbance. Here, right, the causes are unknown. The causes are unknown. This one, what happens is, guys, you know, in our normal GI tract, the villi are nicely like this, right? This is what the villi looks like. In tropical sprue, due to some problem, guys, their villi are flattened, right? Villi are flattened, right? So surface area for absorption, less. Surface area for absorption, less, right? So that is one condition, right? Flattened villi, tropical sprue. It's a GI mucosal cell atrophy, right? Gastrointestinal mucosal cell atrophy condition. Okay. Then apart from that, guys, any surgeries, surgical procedures, right? You all know this bariatric surgeries, gastric bypasses. When they do, right? For weight loss, we talked about these. Even in severe arthritis conditions, we said if the patient is obese, too obese, what did we say? There are chances for bariatric surgeries, right? For weight loss, sleeve gastrectomy, right? We have talked about a few of these, right? When you do this, what happens, guys? Gastric acid production reduces, and acidic environment or alkali environment favors iron absorption. Which one? Huh? Acidic environment favors iron absorption, right? So those kinds of things, right? And apart from that, guys, any other drugs, proton pump inhibitors, histamine receptor blockers, right? These kinds of things, antacids, right? Any hydroxide solutions, all of these things can cause that, right? Then increased demand, right? Here, guys, especially we are talking about pregnancy and lactation, right? Pregnancy is the main one. During pregnancy, guys, if iron supplements are not taken, highly likely that they will go into iron deficiency. Okay, iron deficiency, right? And then menorrhagia, right? Menorrhagia. How is menorrhagia defined? How do we define menorrhagia? Greater than, what's the volume? A normal menstrual cycle, normal menstrual period. What is the volume of blood, guys? Lost? Normal?
110.
Sorry?
ml, under 10 ml. I don't know.
110 ml.
Under 10.
Oh, under 10 ml. Yeah, okay. I was also surprised when I heard 110. No, usually it's around 30 to 40 ml throughout. So you all know, one period lasts for about 5 days of bleeding, right? There you lose about 30 to 40 ml. 30 to 40 ml. Menorrhagia is if you lose greater than 80 ml, right? Or another definition is if the period is greater than 8 days. 8 days, right? Okay, bleeding for more than 8 days or loss of more than 80 ml of blood. This is menorrhagia, right? So when that is there, also increased demand. Okay, right? Then, guys, the last one, increased losses. Here, guys, we are basically, again, you can add menorrhagia here as well, right? Menorrhagia here as well. But here we are talking about some special other GI losses, right? GI losses, guys. What I want you all to know, one of the most important ones, especially in developed countries, right? Now, what do we say? Iron deficiency is usually in poorer regions, but in developed countries also, they can have due to hookworm infestations, right? Hookworm infestations, right? They cause gastrointestinal bleeding, right? And therefore loss of blood from the GI tract, right? And because of that, iron deficiency, right? And then apart from that, guys, perforating ulcers, peptic ulcers, right? Peptic ulcers, duodenal ulcers, any of the two, right? Certain gastric carcinomas, right? Gastric carcinomas, right? NSAID, you all know. I taught you all the chapter on ulcers, no? Do you all remember? Remember, we did some hypothesis. No NSAID, no ulcer. Huh? I hope you all remember those. Huh? So NSAIDs, chronic use of NSAIDs can cause ulcers and bleeding, right? Then other genetic diseases, guys. Meckel's diverticulum, right? We are not going to talk about these now, right? Meckel's diverticulum. Hemorrhoids, right? Hemorrhoids or piles. Hemorrhoids, piles, these kinds of conditions, right? All of these can cause GI blood losses, right? GI blood losses resulting in anemia, right? Okay. Now, these GI losses, guys, why did I mention this here? These are not very high yield, guys. You don't commonly come across these conditions, right? These main cause of iron deficiency is poor intake, right? Then you have all of these other reasons, pregnancies, menorrhagia, right? All of these are much more common. The GI losses not very common, right? Hookworm infestations, perforating ulcers, not very common. But why did I want to inform you this? As a doctor, when you are working, you get iron deficiency patient, right? You are treating them, you are giving them oral iron, not working, not working. Giving them, not working. What should you do? Further investigation into the GI tract, because if something is wrong in the GI tract, no matter how much oral iron you give, pointless, right? Okay, right. Okay, last few points, guys. Look at this. Now we'll come to the diagnostics, right? So we have maybe about half an hour left work. Do you all want to take a break or finish it off? What do you all think? No, no break. I see you all saying no in a very sad face. No, sir, no break. Yeah, send me some messages. Let me see the chat. What do you all want to do? Fin. What is fin? Finish it fast. Small break. Finish it. Continue. Okay, guys. Okay, so there's about, okay, I think only Tarinder wants a break. It's okay, Tarinder, right? Power through. Power through. Let's power through this. Right? Look at this. Diagnostics. Right? First one. Right? We'll talk about the lab diagnostics, guys. First one, when you look at their blood sample, when you look at their blood picture, what can we see? Microcytic hypochromic anemia. Now, how does this happen? Right? How does this happen? Why does this happen? Look at this, guys. First thing, we'll go step by step. Right? Now you all tell me, right? I'm going to go step by step. You all tell me what I should write. I'm telling we have a patient. I will start the first step. Iron deficiency. Right? Iron deficiency. Now, when we have a patient with iron deficiency, tell me this, what is happening to his stored iron? Stored iron. Remember when I say stored iron, will they be kept in storage or will they be released into blood? What is happening? Tell me. Released into blood. So write that stored iron released into blood. Right? Stored iron is released into blood. So what are the two forms? We have ferritin being released into blood. And you all know hemosiderin. Usually it's not directly released. Hemosiderin will be broken down into ferritin and that will be released into blood. Right? Okay. Right? Right. Look at this. Now, ferritin is released into blood. Right? Initially, ferritin will be a little in the normal range or a little bit high. But in a case of severe iron deficiency, do you think these ferritin releases will be enough? Severe iron deficiency? No. So what is happening, guys? Ferritin, serum ferritin, you can say, is excessively used up. Right? Serum ferritin will be excessively used up because the patient is iron deficient. They want to take as much iron as possible. So what happens to serum ferritin? It's going to be low. Serum ferritin is an indicator of what?
Total body store.
Yeah, your body's iron stores, your total body iron stores, right? Serum ferritin is a good indicator of that, right? Okay. So if serum ferritin is low, right? Eventually what is happening, guys? Whatever iron is there is being used up, right? One point I wanted to mention to you all here, guys. Come a little bit up here. Here, we didn't talk about what happens here. Serum ferritin, once it's there, now it needs to be transported into. Okay, serum ferritin, does it transport along the body? Serum ferritin, does it transport like that along the body? Do we prefer transporting it? How do we transport iron? What is the preferred method? Transferring. Now, what did we say about the liver? Liver always produces excess transferring, right? Why? One of the other places is here. Here we will have some empty transferrins readily waiting, right? When this ferritin arrives. This ferritin, guys, is a special structure. This is okay. Y'all can put a side note here. Ferritin looks something like this. Actually, the structure looks something like this, although I drew this green circle with a blue star in the middle. This ferritin is made of multiple protein components. And what did we say? They can have up to 4,500 to 5,000, right? Ferric ions here. Whenever they want to release the ferric ions, guys, this apoferritin molecule, the ferritin molecule, has a special property. It can disintegrate like this. These pieces can separate, guys, right? It can disintegrate whenever necessary and release whatever was in the middle to the outside, right? Okay. And then it's not done there. What can it do? After its job is done, it can reassemble, guys. Reassemble like this, right? And go back to the storage organs and wait for more iron to come. This is a special property. This is not for our chapter today, right? But what is interesting about this? What is interesting about this? Do you all know targeted therapies, guys, for cancers and all under research? So this apoferritin molecules are highly under research these days for this targeted drug therapies. Why? It can go where it's necessary, disintegrate, release the thing, be back home, and can be taken back out. Okay. So for the targeted drug therapy, that's just an extra note for you. So anyway, end of the day, what will happen? These can disintegrate and release this iron, right? Iron can be released, and then the cycle will continue, right? Just that part, we didn't mention it there. Now look at this. When the serum ferritin is low, right? When the serum ferritin is low, from the picture that we just drew, what is the next iron profile candidate that will also reduce? The candidates in the iron profile. What is happening to this serum ferritin? We just drew it here. It is low. It is so what is going to reduce now when serum ferritin is low? What is going to reduce? Tell. Answer. Serum ferritin reduced means what will reduce? Guys, are you all answering? Am I not hearing? Or? What happens? Okay. When serum, okay, I will tell you. When serum ferritin reduces, serum iron reduces. What is serum iron? What is serum iron?
Transferrin bound.
Transferrin bound with iron. Transferrin bound with iron reduces. Right? We are going step by step. We are going all these steps one by one. Right. Now look at this, guys. When serum iron reduces, what does the liver do, guys? Liver, in an attempt to compensate, right? You all can write this. The liver, in an attempt to compensate, further increases transferrin synthesis. Transferrin synthesis. You all know, we already know, liver already, guys, produces an excess of transferrin. Right? Under normal physiology, it produces an excess of transferrin to get as much iron as possible. Now, when the iron is lower, what does it do? In an attempt to compensate, it produces even more transferrin. Now, look at this, guys. This is what it's going to look like. Let's draw this healthy person, right? In a healthy person, what happens? In a healthy person, guys, we have I will draw all the transferrins joined together like this, easier for me. So if we take about 10 transferrins, about 3 will be saturated like this, right? About 33%, no, roughly, right? Something like this. This is a healthy person, right? They always produce a little bit of excess transferrin. Now look at this, guys. When the serum iron is low, plus liver is trying to compensate by producing, liver production of transferrin is high. What happens, guys? What will it look like? Now, previously we had, let's say, 4 molecules of iron. Now what is happening? Transferrin increased to a great extent. But do we have enough iron to come and bind here? Do we have enough iron to come and bind here? Serum iron is low, right? We have only maybe 1 bar. Do you see what is happening? Right? Do you see what is happening? Now tell me this. What can you tell me in an iron deficiency patient? What is happening to his total iron binding capacity in an iron deficient person?
Decreases.
Huh?
Decrease. Oh, sorry, capacity increases, but
What's the definition of total iron binding capacity? What's the definition of TIBC?
total transferrin plus transferrin bound to iron.
Yeah, free transferrin plus bound with iron, both together, right? Now here in iron deficiency, what is happening? TIBC increases. Why? Right? Although the bound is low, the free ones increase a lot. Why? Liver is trying to compensate. Liver is trying to compensate. Very important to understand this. Iron deficiency anemia, right? Serum ferritin low, serum iron low, TIBC high. TIBC high. This is your iron profile. Iron profile. Did everyone understand this point about TIBC? If you all didn't understand, it's a big issue there. Give me a thumbs up. Let me see some thumbs. Okay. Dilshani understood? All good? Right. Excellent. Right. Okay. Now, look at this, guys. All of these things, where does it eventually come and affect? Now look at this. So in the blood, if you look at the blood sample, I'm just drawing a picture. Will you have more transferrins which are bound with iron, or more transferrins which are free now? What will you have more? Free ones. The free ones will be more. The free ones will be more. Now what will happen in the erythropoiesis, right? We talked about this will come into the erythroblast and it will bind into the erythroblast. We said they have the transferrin receptors. Now what is binding? Iron-less transferrin. Iron-less transferrin is coming and binding, right? Second, right. Iron-less transferrin is coming and binding, right? And that will be taken in, right? So eventually, right, what is happening, guys? Iron loading into the erythroblast. Iron loading into erythroblast is going to be less. Iron loading into erythroblast is going to be less. If that is the case, incorporation of iron into the protoporphyrin ring, you all can write this down. Incorporation of ferrous iron into the protoporphyrin ring reduces, right? Okay, if that is the case, heme formation reduces, right? Heme formation reduces. What happens when heme formation reduces? You all know, guys, our RBC, they have, so hemoglobin is around the corners, and in the center we have this thing called the central pallor, right? Central pallor. Now if heme is less, what happens to the central pallor? Central pallor will increase. So heme will be only a very little bit. The pale region in the center increases in size, right? This is what we call hypochromic RBCs. Hypochromic color. The color is less. Hypochromic RBC, right? So now what does iron deficiency anemia have? Microcytic hypochromic. Now the hypochromic part we have discussed. How does it give rise to this microcyte, the small size, right? Small size, guys. Here is the explanation, right? In erythropoiesis, right? You all know, I have put the picture in your book. The principle is, guys, as erythropoiesis happens, the cell, it divides and it divides and it divides and it becomes smaller, right? Something like this. Eventually, we get the reticulocyte and finally the erythrocyte, RBC, right? RBC is the smallest one, right? This is how normal erythropoiesis is, no? Right? Somewhere here, guys, usually somewhere here, just before, so this is the reticulocyte, right? Somewhere between here to here, right? The late erythroblast, right? I have put the picture in your book, huh? Here, right? Somewhere from the late erythroblast to the normoblast. Somewhere around here is when hemoglobin starts accumulating. Hemoglobin starts accumulating, right? So somewhere in here to here, HB starts accumulating. HB starts accumulating. Now what happens, guys? What happens? Since there is deficiency of hemoglobin, right? The RBC has to stay much longer inside the bone marrow to get that. We call this, guys, the critical threshold. Somewhere here we will reach the critical threshold of hemoglobin. Once the critical threshold of hemoglobin is reached, guys, once that is reached, the RBC doesn't reduce in size drastically, right? Few more divisions. Next step is reticulocyte, a little bit smaller, and then the RBC, a little bit more smaller. That's it, comes into circulation, right? So once that critical threshold of hemoglobin is reached, a little bit smaller for the reticulocyte, it becomes a little bit smaller. Then again to the next stage, the RBC, erythrocyte stage, it becomes a little bit smaller, right? So let's say here, let's say I'm just giving this centimeters to make it clear. Huh? Let's say this cell was 20 centimeters. Huh? Let's say it becomes 15 centimeter here, and RBC, the diameter is, let's say, 20 centimeter. I'm just giving this centimeter values, huh? Not 20 centimeter, right? Now, once the critical threshold is reached, it's only that much. But if HB is deficient, can you reach this critical threshold of HB easily? No, right? So the RBC has to stay and stay and stay in the bone marrow for a long period of time. So what will happen during that stay, guys? This will further decrease in size, right? Now the reticulocyte will be somewhere here. And that critical state, let's say the HB is being filled, right? HB is being filled. HB is like that, like that, like that. Here, once we reach this critical stage, guys, right? No more HB can be filled into this RBC. No more HB can, because this RBC is full of hemoglobin. So that's why it doesn't get a lot smaller after that, right? Because it can't get physically, it cannot get a lot more smaller because there it's full of hemoglobin, right? The nucleus will be removed. That's why you can get it a little bit more smaller, right? But that's it. That's it. Beyond that, it doesn't get any more smaller. But now what is happening? Nucleus will be removed much more later, guys. Nucleus will be removed much more later. Until then, because hemoglobin is not filling, only in the very corners there will be a little bit of hemoglobin, not enough hemoglobin to fill it. Critical threshold cannot be reached. Therefore, what is happening? RBC gets smaller and smaller and smaller and smaller and smaller. Finally, right? It will come to that tiny size. Okay, let me draw it somewhere here, right? Okay, that is the reticulocyte, one more smaller than that, right? And that will give the microcytosis. Did everyone understand this concept? Right? Because the hemoglobin is insufficient to reach that critical threshold and stop the further, how do I say, making the RBC smaller. Huh? In a normal person, that's how it happens, right? In iron deficiency, it's a little bit complex to understand this, right? When the longer it stays, to try and reach that critical threshold, it keeps getting smaller and smaller and smaller, right? If you all understand up to that much enough, right? Okay, so that is how it forms microcytic hypochromic anemia. Here, guys, we have to talk a little bit about some values, right? We have MCV, MCH, MCHC. Mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration. Please draw normal versus IDA, right? Normal versus IDA. Mean corpuscular volume, guys, in a normal RBC, these are your first year, second year work. What is the value normally? The range. Normally 80 to 100 femtoliters, right? 80 to 100 femtoliter, right? 80 to 100. So in iron deficiency anemia, it is less than 80, guys. Less than 80. Mean corpuscular hemoglobin concentration in picograms, guys. We say usually the range is about 27 to 32 picograms. Picograms, right? In iron deficiency anemia, it's less than 27, right? And then mean corpuscular hemoglobin concentration, right? This is about, we say 33%, we say 30 to 35%, about, right? And in iron deficiency anemia, it's less than 30%. Okay, all right. Okay. All right. Then guys, so because of this, now what did we say? The RBC stays a long period of time trying to get that proper hemoglobin concentration. Until then, it gets smaller and smaller. At the same time, guys, the longer it stays, right, higher chance for damage, right? Higher chance for abnormal structure formation. So this is, we get the microcytosis. They will obviously be small RBCs. At the same time, we can get something called poikilocytosis, right? This is varying shapes, guys, varying shapes, right, of RBCs, right? Abnormal shapes, right? We can get flat, elongated, teardrop shapes, sickle shapes, various shapes, right? This is poikilocytosis. And at the same time, as it waits so much time to try and receive the hemoglobin, we can also get what we call anisocytosis. Cytosis. What does this word mean, guys? What is iso? The word iso means what? Similar. And iso, not similar, right? Not similar. So cytosis, the sites are the cells. So the cells are of varying volumes. And isocytosis, right? And isocytosis, varying volumes. Variation of RBC size, variations of RBC size and volume. Now, so what does this mean, guys? Now, usually in a normal person, if you check the blood sample, what is their MCV? 80 to 100, 80 to 100 femtoliter, right? So some of their cell in a normal person, if you look at some of their cells, they will be about 80, some of them may be a little bit bigger, 85, and some of them a little bit bigger, 100, something like this, a normal person, but usually within this range, What is happening in anisocytosis? They will have 50 femtoliter ones. They will have 120 femtoliter ones, right? Very small ones, very large ones, like this. A cocktail of different sizes of the RBC. This is what we call anisocytosis. This one, guys, the difference between the smallest one and the largest one, this is what we call the reticulocyte distribution width, right? RDW, reticulocyte distribution width, right? Okay, reticulocyte distribution width. In a normal person, guys, the reticulocyte distribution width is about 10 to 15% in a normal person, right? 80 to 100 femtoliters, no, nearly 20, right? Nearly 20. So the normal range is 10 to 15%. But what happens in iron deficiency anemia due to this anisocytosis? Reticulocyte distribution width increases, RDW increases. Usually, guys, they go 25, 30 or above, 30 or above, right? Okay, because they have various, very tiny ones and they can have abnormally large ones, right? Okay, understood these, right? Okay, so those are some of your labs. Then we come to the iron profile. Now you all tell me, iron profile, right? Tell me what you see in this, in the iron panel, right? First, I will put this serum iron, right? Serum ferritin, right? total ion binding capacity and percentage saturation, right? Tell me up or down arrow, huh? Up or down, increased or decreased? Tell me. Serum iron. What happens in iron deficiency anemia?
Decrease.
Decrease. Serum ferritin. What happens? Decrease. Just know. What about in very early stages? In very early stages, ferritin will be still enough. Yeah, it will be normal in very early stages. But as time goes, ferritin becomes insufficient because they are excessively used up. Okay, just remember that. TIBC. What happens?
Increases.
Increase. Percentage saturation. What happens? What happens?
Decreases.
Decreases. Did everyone understand these four? The iron profile. If you can get that picture into your mind, guys, especially for this TIBC story, right? The transferrin they are lining up and the iron being filled, right? If you can get that picture into your head, you will never mix this up. Okay, right? TIBC and the percentage saturation, right? Understood this, right? Then the last diagnostic one, number 4 or whatever, I can't remember. Okay, so 1, 2, okay, 2, 3. Number 3, bone marrow biopsy. This is not done, guys. This is not done, not done because you just take the blood sample. But in the case of iron deficiency anemia, what will happen? Stainable iron reduces. What is stainable iron? What is stainable iron? What is stainable iron? What is stainable iron? Hemosiderin. Stainable iron reduces or absent in severe cases, right? And then erythroid hyperplasia. What is this, guys? Erythroid hyperplasia in an attempt, right? When the body detects that your iron is deficient, right? And oxygen transport is going to be reduced. The patient is going into anemia. What is happening? The body tries to make more and more and more RBCs to try and get as much oxygen as possible, right? But there is no iron to load into those to the hemoglobin, right? So if you do the biopsy, you can see a lot of erythroid hyperplasia. The erythroid progenitors will be dividing rapidly to try and produce more and more RBCs, right? Right. Come to the clinical features, guys. Clinical features. I have put some pictures in your books as well, right? First of all, right, you can have, guys, any sign and symptom of anemia, right? Anemia. What can we have? Conjunctival pallor, right? You can put the conjunctiva, you can pull down the patient's conjunctiva, look at the color, right? It will look like a pale pinkish color. Write this down, conjunctival pallor, exertional dyspnea, shortness of breath, right? I think I have put all of these in your note, guys. Where is? Yeah, here we go. Okay, pallor. Okay, conjunctival pallor. Skin pallor, guys, it comes if it's severe. Usually in iron deficiency, it doesn't get that severe, like a hemolytic anemia or something like that. Hemorrhagic shock anemia there, right? In those cases, we get skin pallor as well. But in iron deficiency, it's basically generally the conjunctiva only, right? Shortness of breath, exertional dyspnea. Again, why? Not enough hemoglobin, right? All this tachycardia, all of these can happen as a compensation for hypoxia. Tachycardia, functional murmurs, right? Rapidly bounding pulse, these can be there, right? When oxygen is low. Vertigo, tinnitus, this is rare, right? This is when the, because the hemoglobin is low, hypoxia affecting the CNS, right? Hypoxia affecting the CNS, right? Not very common, right? And then in chronic cases, guys, obviously what is happening? What is happening, guys? When we have iron deficiency anemia, hemoglobin is less, oxygen transport is less. So our body's organs and organ systems start getting hypoxic little by little. So one of the main places where you see this in the patients is related to skin. So skin of the scalp, right? When they don't receive enough oxygen, what is happening? Hair loss, alopecia, right? skin around this your oral mucosa, guys, around here, right? Angular, I think I have put a picture here. Yeah, this is angular stomatitis, guys, right? See, due to hypoxia, right? This wounding, right? And sometimes there can be a little bit of fungal infestations, right? Removing of the skin, extreme dryness, right? And general damage in these areas. This is called angular stomatitis, right? And then same way, atrophic glossitis, guys. Atrophic glossitis is when you, due to the hypoxia, you all know in our tongue, there are papilla. We talked about this in the GI system, in the introduction part, right? These papilla are lost, guys, right? Again, due to the hypoxia and abnormal cell proliferation, cell growth. So this is sometimes called beef tongue as well, right? So loss of the tongue becomes extremely smooth, right? Okay. Atrophic glossitis, right? And then koilonychia. What is this koilonychia, guys? Again, due to hypoxia, right? And abnormal cell growth. Now, don't think about hypoxia and what is the other nail feature, guys? Chronic hypoxia. Huh? What is the other? If I do like this, will you all remember?
Clubbing.
Clubbing. That is another case of hypoxia that is due to lung related issues, guys, right? Here, due to hemoglobin related issues, it's a problem with the blood. Here it is a spoon shape. We don't need to talk this spoon shape. Okay, I drew a sickle. Draw a spoon. You all know to draw a spoon. Yeah, right. So spoon shaped fingers is koilonychia, right? The mechanisms a little bit complex, guys. I did a little bit of reading, but it might confuse some of you all, so I don't want to go into it. Right? If anyone's interested, just drop me a message. I will drop some articles. Right? Right. That's about that. And they can have signs and, apart from these guys, signs and symptoms of any underlying cause. As a good doctor, always look for them, because iron deficiency anemia is usually not a disease by itself. It is usually a manifestation of some other condition. It can be a diet related issue or GI related issue or some other pathology, right? Iron deficiency anemia is usually not a disease alone by itself. It can happen, right? But most of the time it happens because of something, right? So look for any underlying causes, right? It can be diet related problems, menorrhagia, ulcers, whatever, right? Hookworm infestations, anything, right? Then guys, rarely, this one, not very common, right? I still have not seen a patient, right? I know I haven't, been working for a long time, but I still haven't seen a patient in university or even outside in the hospital having this Plummer-Vinson syndrome. Is a rare condition, again happens due to the abnormalities in the RBCs and the reduced oxygen delivery. What happens, guys, in the esophagus, there are these web formations, right? We call this esophageal webs, right? Esophageal webs together with atrophic glossitis and iron deficiency or microcytic hypochromic anemia. Right? This is Plummer-Vinson syndrome, right? Very rare, guys. Sometimes if the webs are formed and cannot be easily removed, right? We have to go for surgery, right? Sometimes you have to cut off parts of the esophagus as well, right? It can get that bad. Okay, so it's very rare. Right? And a very severe case. Okay. Right. Then we come to the treatment, guys. Let's quickly do the treatment, right? Look at this. First thing, treat the underlying cause. Try to find out why this patient is having iron deficiency anemia. If they are from an already endemic region, right, or a population where the iron deficiency is prevalent, then okay, right? Then okay, you know, this area, probably the dietary issues, they're not getting enough nutrients, then fine. If not, always try to find what is causing the iron deficiency anemia. Okay. Then iron supplementations, guys. We mainly have two, oral and IV. Oral is the first line, right? Oral is the first line. We have three options, guys. I have put only two. Ferrous sulfate, ferrous gluconate, and put the third one, ferrous fumarate. Fumarate. Okay. Ferrous sulfate, ferrous gluconate, and ferrous fumarate. Right? Ferrous sulfate, guys, if you look at the elemental iron in these medications, right? Fumarate has the highest one. 33% of the drug has elemental iron, right? Ferrous sulfate has about 20%, and gluconate has the least, about 10 to 12%, right? So this fumarate, this is why I didn't put it here. Fumarate we don't usually use, guys, right? We manage with sulfate and gluconate, right? Most of the time, fumarate is a little bit too strong, right? The side effect profile is a little bit high. Okay, so ferrous sulfate is what we prefer, right? Depends on the patient situation, guys. Dosing you all do not need to know, right? It's 100 to 200 milligram TDS, right? Thrice daily, but that will differ. For example, some patients will come and complain of severe side effects, right? If that is the case, you can reduce the dose maybe once a day, sometimes once in 2 or 3 days, right? So it's a clinical judgment, right? It's a clinical judgment based on the patient's situation, side effects, and their deficiency level, right? Side effects from the oral one, guys, just know you have to know these because a lot of patients actually complain of side effects from iron, guys, from taking iron supplementation, right? Nausea and vomiting, diarrhea, right? Some patients complain of constipation. So you can prescribe a stool softener or something like that. And black stools, guys. Black stool, it just happens because of the iron is reacting with your gut microbes, right? Your gut microbes, they interact with the iron, right? So they change the color. They change the color of your stool. It becomes black. It's actually, guys, a dark green. If you see it, it's a very dark green. It's a very dark green, but most of the patients, they will come and complain to you as black. So when they complain as black, what's the issue? Black tarry stools. Where do you see?
GI bleeding.
Yes, upper GI bleeding, right? So you have to take a stool sample just to make sure the patient is not having something like that. Although they come and say black stool, we cannot tell them you put a torch and look and tell me if it is black or very, very dark green. You cannot say that, right? If you say, doctor, I don't know, it looks dark, right? And I'm scared. They actually, a lot of patients will complain, guys. A lot of patients actually freak out when they see black stool, tarry stool, right? Right. And you can write metallic taste in the mouth, right? All of these staining of the teeth, right? Metallic staining, metallic taste in mouth, staining of teeth, all of these can happen, okay, due to the iron. Again, remember, if you're giving oral iron and it's not working, one thing you should suspect is a problem with some sort of inflammatory disease, right? We talked about hepcidin, right? Remember those points, hepcidin, right? And the other thing you should suspect, any sort of GI problem, right? Be it worms, be it peptic ulcers, perforating ulcers, whatever, right? Blood loss, right? You have to think of those if you're giving oral iron and it's not working, right? The second one is IV, guys. Before we come to the IV, just I want you all to mention, how do you monitor this oral iron success, the success of the progression of your treatment? Hemoglobin must increase, write this down, must increase by 1 gram per deciliter per week in the patient, right? If this is not happening, some other underlying cause is still causing a reduction of hemoglobin, right? Hemoglobin must increase by 1 gram per deciliter per week, okay? Right, then the next thing. Now, okay, we are giving iron, oral iron. Now, let's say the patient reaches normal hemoglobin levels. Let's say they reach about 15, let's say they say 12 to somewhere around 15 grams per deciliter. Okay, hemoglobin is normal. You do the blood sample, hemoglobin is normal. Do we stop iron there? Do we stop iron? Yes or no? Why? Why?
No.
Why?
No, otherwise it will
Yes.
go back to anemic.
Yeah, go back to anemic. Why? Why? What are you not doing? If you immediately stop, what is the bad thing that you're doing?
The stores.
Yes, you have not yet replenished the stores, right? You have replenished the blood iron levels, but you haven't replenished the stores. So guys, you do not stop. Although the hemoglobin reaches normal levels in the patient's blood, do not stop iron supplementations up to 3 to 6 months, guys. You have to give supplementation, right? To replenish the stores, right? To replenish the stores. Why are stores so important? We have already talked about, right? We talked about the recycling, how little is coming from the diet, rest of it all is a job from the stores. Okay, so you have to replenish the stores, right? Right. So usually, guys, you need to continue it, right? You need to continue it until the transfer in saturation is greater than 20%. The transfer in saturation, we said normally is about 20 to 50%, right? We use 33 as an example. Until it's about greater than 20, you must continue. Just because hemoglobin becomes normal, not sufficient, right? Not sufficient. Usually it takes about 3 to 6 months, depending on how severe the patient had it, right? Then the final one, IV. IV, guys, not commonly used. We have two options, IV sorbitol and IV dextran. This is used in specific scenario when oral iron is either not working or intolerable by the patient, right? So for example, severe side effects from oral iron. These are indications. I'm right. Put the topic as indications for IV. Severe side effects from the oral drug, from oral iron, or patient who has done a gastric bypass. Patient already done, just right, gastric bypass, right? A bariatric surgery, right? Sleeve gastrectomy or something like that. Okay. And then patients sometimes with severe chronic inflammatory diseases, right? Severe chronic inflammatory diseases, for example, severe SLE, right? We have severe rheumatoid arthritis, right? Severe IBD, right? These kinds of cases, guys, severe ones, mild to moderate, not a big problem. Severe cases are the issue when they have chronic inflammation, right? What is happening when inflammation is there? What is happening? Hepcidin is high. When hepcidin is high, what is happening? Why? What's happening?
Transporter.
Inhibit the transporter, so iron absorption drops. Right, excellent. Right, this one, guys, IV is not preferred. Why? Right, the injection site, they can have severe pain, guys. Injection site pain is very high, right? Okay, where did I go? Yeah, injection site pain is very high, right? And on the other side, guys, it can cause staining of the skin, right? Like a blackish appearance, guys, wherever you inject, right? Okay, right? So that's it for iron deficiency anemia. Okay, right? Did everyone understand everything? So it's a relatively your most high yield, guys, for your exams. For your exams, most high yield is this, right? Your iron profile, this part, right? But clinically, there is a lot to think about, especially, right? So when you are working in other departments, rheumatology especially, GI, you have to think about your treatment protocols and how your treatments can affect with what's already going on with the patient. Okay. Right now, arthritis especially. So currently I'm also working in rheumatology section, right? We get a lot of arthritis patients, and one of the main things what the consultants prescribe includes glycosamine, right, and calcium supplementation, right? So calcium supplementation, remember what's the problem? Can inhibit both forms of iron absorption. So usually when we tell them to come for the next visit, we always tell them bring the iron profile as well, right? So those are clinically important things. For the exams, they won't ask you all those. Huh? Okay, right? So those are what you need to think about. Right, all good? Right, give me a thumbs up. Right, okay. Right, I will see you guys again tomorrow for thalassemia. I will put the time and the skeletal note by tonight. Huh? Right, okay guys, see you guys again tomorrow. If you all have any questions, drop me a message on WhatsApp. Huh? Right.
Right. Thank you.
Right, no
Thank you.
problem.